Okay, so we were looking at some of the dietary restrictions for MAOIs. So if you notice, most of the foods are like cured deli foods, aged cheese, pickled herrings, fermented foods. So it's good to have an idea of what these are so you can educate your patients to stay away from them, to avoid them. There are some foods that are allowed in moderation. That is the cottage cheese, the cream cheese, yogurt, spinach, tomatoes, and there's the list. Then we have another class of drugs. These are tricyclic antidepressants. Again, these are not first line. Tricyclics are second line class of drugs. That's you'd see pretty frequently the Elavil, the Senequa, the Remron, the Anafranil. You'll see those ones prescribed very often. The Pamelor is pretty common too. Again, prescribed for anxious and depressive disorders. Disadvantages, and this is why they're not used as first line, is that they can cause an anticholinergic side effect, particularly urinary retention. The patients could have severe headaches. You said Remron is for appetite. You see it prescribed for appetite, Shannon?
They use it for appetite for a lot of patients.
For who?
Dementia patients.
Oh, I didn't know that.
They use it for appetite, like an appetite stimulant. They're losing weight.
Oh, that is good to know. Thank you for sharing that. Patients can get severe headaches, blurred vision, agitation, usually not used if there's pregnancy, glaucoma, or cardiovascular issues. So very often, more often than not, you have patients that become pregnant while in treatment. So if a patient becomes pregnant in treatment, it's usually risk versus benefits. So I would ask them again to set an ROI so I can reach out to their OBGYN and say, hey, these are the lists of medications that Jane is on. I need a written permission from you that it's okay to keep Jane on these drugs. And these are drugs that, after I check like pregnancy class, it says it's safe to take. I still don't say, let me go ahead and prescribe. I still want the buy-in from the OBGYN person. And then there are some drugs, for my own safety, I say I am absolutely not prescribing while you're pregnant. Feeding and eating disorders, which is pretty common with our especially adolescent population these days. You still see it. I still have a few adults who have feeding or eating disorders. I had one patient today. She's a long-standing patient of mine, and for the first time she shared that she's been binging and purging. I was like, oh, I guess it's never too late to start. So what causes these feeding or eating disorders? It's usually behavioral. There's usually an affective disorder associated with the eating disorder. What it means is that usually it's not just someone who has an eating disorder. Usually an eating disorder is accompanied by a major depressive disorder, a patient with a borderline personality, anxiety, a patient who has problems with alcohol or substance use, or it lists personality disorder, but a borderline personality is the personality disorder. Usually the bulimia, anorexia, usually those patients have a borderline personality. And as we go through the material, we'll get to the different personality types. Thin, I haven't seen thin. Is that a 15-year-old in the documentary, Christina? Oh yes, that one, oh yes, yes. It certainly is of concern. And it is a very common problem, and I must say it's like it's becoming even more common. I mean, when I was growing up, I knew nothing about binging or purging or starving myself. I knew nothing about that. Is it technology, where everyone is more knowledgeable and engaged in these behaviors, or has society just changed drastically? I mean, I'm not from the archaic ages. It wasn't that long ago I was a teenager, I don't think. Oh, okay. And you knew this like as a teenager when you were growing up? As a young adult, okay. Well, I grew up in a third world country where there was one television in the house with one television station. So my exposure was pretty limited. So again, it is important to know those comorbidities. Yes, I look back and it was sheer innocence then, because the things these kids know now, it's like, whoa. Then we have pica. Pica is pretty common. Usually we see pica in what population? Women who are, specifically women who are pregnant, yes, in pregnancy. So this is the eating of non-nutritious, non-food substances, appropriate for both age and developmental level. It can include paper, soap, anything they can choose to eat. There is no particular cultural support for it, and I guess that's mentioned because in some cultures, people eat things that other cultures don't eat. You have to make sure it's not a cultural thing where they happen to eat soap every first of the month, or they eat soap. Who knows? It could be cultural, so you want to make sure you rule out cultural aspects. Some may be related to vitamin deficiency, zinc, or iron deficiency. And it's important to note here, there was a period where I found myself eating all the erasers off my pencils. An eraser never tasted so good. I would buy pencils just to eat the erasers. And when I say there was a period, I'm talking maybe 3 years ago, it was. I was eating erasers like crazy because they tasted good. And I was in the Air Force at the time, and I had to do a physical, and I had blood drawn. And the following day, they called me. They're like, "You need to come in right now." I'm like, "Oh my goodness, what did they find in my blood?" I go in. I was severely anemic. They're like, "You need to go to the hospital right now." And I went to the hospital. I had a blood transfusion, and here I am today, much better. But I say this to say, I was eating those non-nutritious, non-food substances for quite some time, and I had no idea I was anemic until I had blood work done. So if you find yourself, you hear anyone eating anything that's non-food, yes, I'm on the list. Non-food items. Clay, coal, lots of different things. My sister was just pregnant. She had the baby. My nephew's a month old. And I go in her car and I see powder all over her seatbelt powder. I'm like, "What are you doing with powder?" She goes, "I've been eating powder." She goes and buys the powder just to eat it. So pica is pretty common. It's not associated with autism or intellectual disability because, as we know, people with intellectual disabilities, they will very often eat things that are non-food items. Is my audio and video much better now? Yep. Okay, so I guess I'll start having class in the bathroom. Then we have a rumination disorder. A rumination disorder is repeated regurgitation of food, either rechewed or reswallowed, or if you spit it out. Did I start the recording? Oh, yes, or someone else did. That's good. So this is someone who's chewing their food, swallows, then happens to bring it back up and rechew, reswallow, or they can even spit it out. It occurs several times a week, usually daily. It is not related to a medical or gastrointestinal disorder. It does not occur exclusively during another eating disorder, and it may occur in the context of mental or developmental problem. So that's a rumination disorder. Oh no, what show is this? Because I'm going to make sure I watch it.
I don't remember the name of the show exactly. I think it might be called Diagnosis, but it's about this doctor who basically goes and finds people with disorders that aren't diagnosed and helps them find a diagnosis.
Oh, Diagnosis on Netflix?
Yes.
Oh.
I think the rumination one is like the 4th or 5th episode in.
Yes. I will definitely take a look at it. Thank you, Samantha and Christina. Then we have avoidant restrictive food intake. I have one patient with this disorder. He is Asian. He just turned 18. Strange addiction. Okay. I see you guys have a lot of time to watch television. Oh, wow. I remember myself in nursing school. Things must have gotten a lot better. I'm just messing with you guys. You have to find time to de-stress and relax. You most certainly have to find time for yourself. So I have one patient, he just turned 18 and he has an avoidant restrictive food intake disorder. He does not have any medical or mental health problems that cause the restriction of the food. This is what he chooses to do. He will eat very, very little food, very little throughout the day. He's 18, he looks like he's probably like 12. And he avoids food because he doesn't like, very often it's not the taste, it's what's the word I'm looking for? Like the feel of the food. Like he doesn't like a lot of, yes, thank you, texture. He doesn't like the texture of the food, so very often he will avoid food for that reason. It is so bad that every night he gets an all-night tube feed. And he's okay with it now. He takes his tube feed all night, but we're trying, myself, therapist, and his parents, and his dietitian are working with them to see if we can get him off this tube feed because he's in his senior year of high school. He's planning to go away to college. Next thing you know, he's going to have a girlfriend, and you know how the rest goes with the all-night tube feed and stuff. So we're trying to prepare him for adulthood. And it's a slow process, but we're hoping for success. So this patient will have significant weight loss, they'll have nutritional deficiencies, and they will depend on oral nutritional supplements like he does on the tube feed. Not associated with any cultural practice or from not having enough food, it's a disorder in itself. Then we have anorexia nervosa, which is a lot more common as well. This is restriction of food intake leading to significantly low body weight in context of age, sex, developmental, or physical health. This is pretty common, I must say. This patient, it's uncommon for them to have vomiting, diuretic or laxative use. There's some psychological factors involved. They have a distorted self-image. There's a fear of being fat. Sometimes it's for control or in an effort to be perfect. Some signs and symptoms, physical signs and symptoms. This person may have growth of lanugo, cardiac arrhythmias, early osteoporosis, hair loss, issues with amenorrhea or controlling their temperature, and the death rate from anorexia nervosa is pretty high. So you might be thinking, oh, they're just not eating. It is a pretty serious illness, and it is pretty common. I have one patient, she is, I want to say she's in her 60s, and she's been anorexic her whole life. And there's a huge gust of wind. I can envision her falling over. She is cachectic, like very, very small. You should know the physical manifestations of anorexia nervosa. And here's a picture that is a representation of this girl's cognitive distortion. That is what she sees, and this is the reality. You guys should have that picture there. Bulimia nervosa. This is also very, very common, which my patient told me today. Oh, I'm bulimic now. I'm purging. I'm purging when I eat, but I haven't done it since I've been in the hospital. It's a recurrent episode of binge eating. Vomiting or diuretic or laxative abuse is common. So this person will eat, and then they find a way to bring the food out. So this is not anorexia where they're restricting what they're eating. They are eating, but they're not keeping the food in. They're making sure that food comes out. Self-evaluation is unduly influenced by body shape and size. Their weight is usually close to normal. They usually look normal. They often have death by hypokalemia from the constant bringing the food back up. So their compensatory behavior includes purging, enemas, medication, fasting, or even over-exercising. Then we have a binge eating disorder. So we have the anorexic who was restricting how much they eat. We have the bulimic person who was eating, then bringing it up. And then we have the binge eating who just eats, and they're going to eat, and they're going to eat, and they're going to keep that food in. So they have no compensatory behaviors. There's no purging, no laxative, none of that stuff. They're keeping that food. So this patient is usually overweight, even obese. There's a sense of lack of control. Episodes can include eating more rapidly than usual, feeling uncomfortably full, eating when not hungry, eating when alone because they're embarrassed. So they're aware of this, but they will just eat and eat and eat. I remember I worked with a nurse when I worked in corrections who had a binge eating disorder, and we'd work second shift together. And sometimes she'll order 2 large pizzas, and I would never see her eat it. But when I went to do the med pass and came back, the boxes would be in the garbage. She'd bring a lunch box in, and the lunch box will be filled with just candy. And it's a disorder. It's not like they can consciously make that decision to not eat. They need help. We had spoken about non-pharmacological treatments in our last class. So this is where we would use like cognitive behavioral therapy, because there's no pill to say stop eating that I can prescribe. They need to look at the thoughts, like what are you feeling when you feel like eating? Like does something happen, or are you in a certain phase, like triggers? So lots of different things they need to find. And then in doing so, they engage in those cognitive behavioral therapies, and it'll help to hopefully address those behaviors. We have Enco Paresis. This is the repeated passage of stool in inappropriate places, whether involuntary or intentional. It lasts anywhere from 1 to 3 months. The chronological age must be at least 4 years, because I mean, a child 1, 2, 3 pooping and peeing in their pants is normal stuff. It is not due to any medical condition, so this child cannot have a medical condition if they're pooping their pants. Then it's going to be from the medical issue, not Enco Paresis or on its own. So there's primary and secondary types. Primary, this child was never previously trained. Secondary, this child was trained at some point, and now they're now they're pooping in their pants. We have enuresis. This is repeated voiding of urine during day or night into the bed or clothes, or whether involuntary or intentional. So this child is going to be peeing or pooping on themselves. Enuresis pee and coparesis poop. It occurs at least 2 weeks for 3 months. It causes significant distress or impairment, because just imagine if this child is older. It's going to cause a lot of distress if they're older. It is not associated with family or psychological factors. There's a genetic factor. So if you're a bedwetter, chances are your child will also be a bedwetter. So how do you think you can address this?
My son was a bedwetter. They said reduce fluid intake and the amount of time, like stop it at 6 p.m.
Yes. And they also have pads out there where if any, like the first drop of water, it'll wake them up, like lots of different things. Usually pediatricians try to address this issue. How old is he now?
He's about to be 14.
Okay.
He went to bed until he was 7 years old, and no one in my family is a bedwetter. Never has. So I don't know.
Did he have a medical condition or anything that could account for it?
No. He was just a very heavy sleeper. He slept through anything.
Maybe it wasn't some great-grand, maybe somewhere down the gene line.
Maybe.
Then we have separation anxiety. This is where, every child gets anxious, but it's not just children. It could be adults too. You ever hear anyone talk about that clingy boyfriend or the clingy girlfriend? Every time I leave, she's calling me, where are you, wanting to come back home? Or that child who's in high school and wanting to be home with their parents. Separation anxiety. This is excessive anxiety concerning separation from home or from those whom the person is attached, lasting at least 4 weeks in children and adolescents, 6 months or more in adults. Usually begins before age 18, may develop after some life stressor. So I see this sometimes, and it's very often like changes in the child's life. A divorce, they move. So usually after a change is when it usually appears in my experience. So this child will worry. I worked as a school nurse for 10 years, and there were some kids, they had separation anxiety. They will come down to the nurse's office, especially on a Monday morning. I want my mom. Can I please call my mom? I just need to know that she's okay. I just need to talk to her for a little. So this child will worry about harm to their major attachment figure, whether it be mom, dad, whoever it is. They'll worry about events that could cause harm or could cause them to be separated from this attachment figure. They will worry about being left alone. They'll have nightmares, disturbed sleep, difficulties in school, somatic complaints. And I can speak to the somatic complaints because that's the same child that comes down very often throughout the week. My stomach hurts. Can you just please call my mom? Or I think I need to go home. No, rest and back to class, because you kind of get to know your frequent flyers or the kids that are presenting with somatic symptoms, that is. Your nursing interventions, be sure you always consider the child's developmental stage. Proper communication, how you would communicate with adults, is not always the same you communicate with children. You can use play when necessary. Sometimes that's the best way to get your message across. Look at family dynamics, family stressors. Are they committed to the treatment? So when you make a referral or for care or anything, just make sure that you have buy-in from your patient or they're vested in following through. Look carefully at any safety issues. A child has Enco Paresis, you probably want to ask a little bit more question. Enuresis, because sometimes this could happen after a traumatic event where they abused, did something happen. So you want to make sure safety is accounted for. Look at the child's relationships. Again, make sure you're having good boundaries. If kids, it's kind of harder, so cute and cuddly, just want to hug them, but boundaries is still a professional relationship. When you make plans for your patients, make sure you involve both the patient, the family, and the treatment team. So don't make a plan and then you tell the family, oh, little Susan needs to go here on these days. And no, you have to make sure you look at the child holistically and involve the parents and everyone else in their care. Always work to promote normal growth and development and improve function in children. So some of the recommendations along with medications could include family, individual, or group therapy. And when I recommend therapy, especially to kids, a lot of parents is like, oh, he did therapy before, he didn't really like it. And I'll ask, what kind of therapy was it? Because is little Susie 6 and you're expecting to engage Susie in talk for half an hour, 40 minutes? It's not going to happen. So I'll tell the patients, make sure you're finding someone who can engage in like play therapy, art therapy, to get the kid engaged or to get them going without even realizing that they're actually doing therapy sessions. If they're taking medications, make sure you educate them about duration, any special considerations for taking, and such. Any questions about the mental health issues of children and adolescents, eating disorders? You guys want to go right into psychotic disorders, or do you want to break? So if I hear nothing, I'm going to figure you want to go straight through. Okay. Okay, no. So I can see you guys are trying to get out early. I'm just a fast talker. If I am ever going too fast, please don't hesitate to slow me down. Psychotic disorders. So this is the bane of my existence. This is where I live. Psychotic disorders. Psychotic disorders, we have schizophrenia, schizophrenic form, schizoaffective, delusional, brief psychotic, shared psychotic. Schizophrenia. I did not know schizophrenia. You hear about schizophrenia, like if I'm watching TV or something, but how often do you encounter someone in life that has schizophrenia? You probably think you don't, but you do. It's pretty common. It's actually pretty common. It affects men and women equally. Men, earlier onset, usually in their mid-20s. I have many patients, especially my male patients, will tell me. I have one patient, it is so sad. He works at a grocery store collecting carts. This is a patient that had a full right to college, full athletic right to college. He did his first year, excelling well academically. Was in his second year when he started having the psychotic symptoms, had to drop out of school, went home, and it's just downhill from there. And it's sad because if you look at him and he's very disheveled, odorous, his hair, and he needs a haircut. If you talk to him, he is so well spoken. You can tell he's educated. And you probably see him at the grocery store pushing carts, and you probably grab your child's arm and go over to the other side of the aisle because he looks questionable. But that's one thing I like about my job, is that I get to know people that I would not normally have an interaction with and get to appreciate people. It is heartbreaking. It is very heartbreaking. And it's just one of the many stories where they had life dreams, they had goals, and they started and boom, mental illness hit and it changed your life forever. Women usually have a later onset, usually in their late 20s. They also exhibit less severe symptoms. Schizophrenia can lead to dramatic health conditions because very often schizophrenics do not follow up with health care. They do not follow recommended treatment. They don't live healthy lifestyles. And they usually have a shorter lifespan. Approximately 5 to 6% commit suicide successfully. They can have premature morbidity, as I mentioned, early death. So there are a lot of theories as to what can cause schizophrenia. There's a genetic theory that it's heritable. That's one theory. There's also a theory that thinks it's a neurobiological cause, where it could be caused by the decreased brain volume in the third ventricle or atrophy of the frontal lobes, cerebellum, hippocampus, or amygdala, or abnormal amounts of dopamine, serotonin, glutamate, and GABA. So there's the neurobiological theory. There's also one where it could be environmental. I guess researchers show it's higher in the urban population, in places where you have winter months. If there was maternal starvation or viral infections, or children born after long labor complications. So those are some theories. There is another theory, the psychodynamic factor theory, that says it could be caused by a distorted mother-child relationship, someone having disorganization with the ego thing, faulty reality interpretation, or it could be behavioral. It could be learned faulty coping and interpersonal skills, or it could be familial, where there's marital difficulties, repressed unhappiness, destructive expressed emotions, issues with communication. So there are lots and lots of different theories as to what could cause it. And lastly, there's the cultural, where it could be one's socioeconomic status, a decrease in having social supports. It's stated here that the prognosis is better in countries where those with schizophrenia are treated as normal. It's found in all countries and all over the world. I grew up in a third world country. So I haven't heard anything about older parents. I grew up in a third world country where mental health care was, I didn't know what anxiety was, didn't know what depression was. I mean, I knew when I felt fear, but I didn't know there was a name for it. You had those people who just weren't quite right. You knew they had a little thing about them. You call them odd. There's some people, a lot of people who were crazy, and they would just walk around on the street, live on the streets because they're crazy. Looking back, they might have very well had schizophrenia and assume that lifestyle. So mental health care, as necessary as it is not very widespread. I'm thankful for America where we have a lot of advancements in our society. So when someone has schizophrenia, they usually have disturbance in their perception, their cognition. So that's the way they see things, the way they reason through things, their emotions, their behaviors, and even in their social relationships. So if you look at all those areas that are disturbed, it tells you that schizophrenia affects every single aspect of their lives. So usually you have signs in schizophrenia. There are some that we call positive signs and some that we call negative signs. Positive signs, I like to think of like you add the positive sign. So it's all the uppers. Negative signs you take away, it's all the downers. So when you think about uppers, you think about hallucinations, delusions, disorganized speech. So when I talk about disorganized speech, there is lots of different speech patterns for a patient with schizophrenia. They could have circumstantial speech where you ask them what time it is. Well, this morning when I got up, I had a shower. I thought I needed a muffin for breakfast, and then I went to work. I got to work kind of late. Oh yeah, and the time is 6:23. So that is circumstantial speech. There is tangential speech where you ask the question and they totally lose focus. You're like, hey, can you tell me what time it is, please? And then they'll probably answer you then. There is perseveration. Perseveration is an important concept to remember. Perseveration. This is where there's repetition of a particular response. I had a patient that lives in a group home, and he would tell me that he would get in trouble with his group home staff because he kept asking them the same thing over and over. I forgot what it was he was asking over and over. And I had to then educate the group home staff that this is a patient with schizophrenia, and perseveration is a symptom of his disorder, which means he is going to ask you the same questions over and over and over. So do not consequence him for a symptom of his mental illness. And it went better moving forward from there. These patients can have word salad. This is where they just use random words. Apple invention, green table eat. And you're like, what? Apple invention, green table eat. And they say it with such conviction and such surety. You're like, am I the only one hearing this? But yes, they can have word salad. They can also have neologisms. This is where they coin new words. You'd be like, what's this? What's a funk? What? A funk? What is that word? That's how someone with schizophrenia, they can present. This is where they coined their new words, neologism. And then there is derarism. You think about derail, getting off track, thinking away from reality. That's a possibility in their speech as well. Positive signs continued. There can be grossly disorganized or even catatonic behavior. What is catatonic behavior? Not responsive, just there, like just sitting like this all day. Or standing and assuming a stance for the entire day or for hours. Staring into space, yes, not responding. There could be music, staring, grimacing, or inappropriate affect. We spoke about affect last class. What did we say affect was? The outward expression of your emotion. Right. So if they have an inappropriate affect, it could be. I remember when I was sitting in with my preceptor when I was still in school to be a nurse practitioner. I remember this patient. It was so concerning. young girl, her mother used to come with her to every appointment, and she had an alcohol problem. And I thought mom needed to step back and realize she was an adult, but she needed mom's help. Not just mom, but her dad. She had moved back in with her parents. She was like probably 24, 25. And the mother would come with her to every appointment. Then mom stopped coming to the appointments. And I remember my preceptor asked her what happened to mom, and she said, oh, she has cancer. We're like, okay. So the subsequent visits, we would ask her how mom is doing. Mom wasn't doing too well. And then one visit, she came in with her boyfriend. I was with my preceptor for over a year. She came in with her boyfriend, and my preceptor asked her, what happened to mom? She died. I was in the back of the room, like mouth on the floor, like, are you kidding me? Yes. And I just remembered how much her mother used to care for her, and here she is laughing that her mother is dead. Do you think she was actually laughing that her mother is dead? No. It's a symptom of her mental illness. Inappropriate affect. Badly. Negative symptoms. These reflect, as I say, negative, the minus sign, takeaway, a diminution or loss of function. So this is your blunted, flattened affect. This is, yeah, I'm so happy. Okay. Blunted affect. Lack of emotion, apathy, lack of motivation, amotivation, lack of speech, alogia. They have emotional impoverishment, loss of emotional warmth. So this is not the person who's going to be in relationships or showing you any kind of affection. They are without it. So that's the negative symptoms of schizophrenia. They'll also have poor eye contact. I have one patient I am yet to take a good look at his face, and I've been treating him for over 2 years. He comes in and he sits like this. Yes. No. Okay. Are we done? Bye, Zoe. That's it. That's his entire visit. No matter how many questions I have, that's exactly how he responds to me. The negative symptoms of schizophrenia. They also have poor hygiene. He's unkept. He smells, and it's not just him. It's several patients that have poor hygiene, and they come into my office, and it is pungent. How do you propose that you handle something like that? You're working on your floor, patient comes in, and they reek. Some Vicks, especially like we're wearing masks now, you rub that Vicks in that mask, you put it on, and you go forward. Or if there is no mask, you grin and you bear it. I keep a refreshener in my desk, and as soon as they leave, I prop my window open, I spray out my room, because I don't want another patient to come in here and think I smell like that. But while that patient is in there all smelly, I laugh and I talk like normal. Because I've come to understand that it is a symptom of their illness. They're not choosing to smell like this. They don't choose not to shower. It is a symptom of their illness. So how is schizophrenia diagnosed? So you don't just have a bunch of positive symptoms, a bunch of negative symptoms, and you go, oh, you have schizophrenia. That's not quite how it works. So we use a manual. Has anyone ever heard of the DSM-5? Yes, yes, and yes. So the DSM-5 is my Bible. So this is the book that tells me how I can go about diagnosing someone. It gives you guidelines. They must have this for this long, for this amount of time, and then you can say it's this. So schizophrenia. These patients should have 2 or more of the following symptoms for a significant portion of a 1-month period. So over a month, they need to have 2 or more of this for a significant portion of this period. Delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, or negative symptoms. So let's go back to delusions. There are different kinds of delusions, and these are very important for you to know. It could be delusions of grandeur, and I say grandeur so you can get an idea of What do you think delusions of grandeur could be? Exactly, thinking you are all that. Well, for my birthday next month, I am having dinner with the governor. Oh, I was sick last week, and you wouldn't imagine who came to see me. The president. Yes, and these are things I hear in my appointments. And it is, I guess because it's work, you get used to it. It is bizarre at times. It can be. It can have delusions of persecution. I know you all don't have your camera on because you're looking at me, aren't you? You all want to hurt me. I can feel it. I know you want to kill me. Delusions of persecution. Ideas of reference. Someone just typed, they think more of themselves than they are. I was thinking that. Are you reading my mind, Christina? Are you reading my mind? So that's where they think that everything in the environment, it relates to them. Or they think they have thought control. So it is not a good place to be, and these patients, they struggle to function in the world, to function in society because they are afflicted with these issues. They can have hallucinations, they can have disorganized speech, and we went through the different speech patterns. They can have disorganized or catatonic behavior or the negative symptoms. So 2 or more must be present for a 1 month period, a significant portion of that period to be diagnosed with schizophrenia. They'll have social or occupational dysfunction in work, relationships, and or self-control. Continuous signs of disturbance persist at least 6 months. So over the month, they're having it a lot, and it must go on for at least 6 months to be diagnosed as schizophrenia. So this is why when you're doing your history taking, you're asking your questions, it is very good to be very thorough and to enlist the assistance of collateral information, wives, kids, to see what's going on. There are different subtypes of schizophrenia. One is the paranoid type. This is the patient who has a preoccupation with delusions or hallucinations. They have little disorganized or affective flattening, so they won't appear disorganized. Their affect will be more than likely appropriate, but they have a preoccupation with delusions or hallucinations. They will not have disorganized speech or disorganized or catatonic behavior, flattening or an inappropriate affect. This is the best prognosis, but it's the most aggressive. Most aggressive as it relates to progressing. You have disorganized type, where all of the following are primary. You have disorganized speech, disorganized behavior, flattened or inappropriate affect. It could be grimacing, poor agreement, rhyming, those clang associations. Early onset, and it's a poor prognosis. You can also have the catatonic type, where you will have at least 2 of the following. Motor immobility as evidenced by cataplexy or stupor, so the patient will just, it's almost as if they're frozen in that position. They'll be in that position for a while. They can have excessive motor activity, apparently purposeless or not influenced by external stimuli. They can have echolalia, echopraxia. They can assume bizarre postures, and that plays into their cataplexy or lack of flexibility. So schizophrenia is a very intricate disorder that has lots of different things going on. There's the undifferentiated type, which means we just don't know what type they are because the positive signs are present, but the criteria is not met for paranoid, disorganized, or catatonic. They have inappropriate affect. They're not a danger. They're a danger to themselves or others. It's poor prognosis, and it just drags on forever. So there are lots and lots of different types. I doubt you will ever be required to know the different types, but just know that someone doesn't have schizophrenia and it's just schizophrenia. You'll probably see a patient with schizophrenia undifferentiated type. So it usually tells you like what type of schizophrenia they have. They can be in the residual phase where they have an absence of the prominent signs of the positive signs of delusions, hallucinations, disorganized speech, or grossly disorganized or catatonic behavior after the first episode. So they could have had this psychotic break, they got treated, and now they're in the residual phase. Continuing evidence of the disturbance is indicated by presence of negative signs and two or more positive signs, but it's in like an attenuated form. So it's more like odd beliefs or unusual perceptuals, not so much hallucinations or delusions. If anyone has seen A Beautiful Mind by John Nash, you should, if you haven't seen it, you should check it out. Schizophrenic form. So schizophrenia and related disorders, you can have a schizophrenic form disorder. So be careful when you're reading the chart, you don't read schizophrenic form and think it's schizophrenia. So symptoms and characteristics are similar to schizophrenia with the following exceptions. The duration is at least 1 month, but less than 6 months. So a patient is presented with all these signs and symptoms. It's happening for most of the month. But remember I had said for schizophrenia, it needs to be more than six months or more. So it's still early in the disease process, or maybe it will never progress past 6 months. So if it's at least 1 month, less than 6 months, it's schizophrenic form. They have deficits in social and occupational functioning, where they may or may not have deficits in those areas. It may be the first diagnosis they get, and it may change to schizophrenia, like I mentioned, if it progresses over the 6 month mark. 1 in 3 patients recover, 2 or 3 will develop schizophrenia. Then a very common one too is the Schizoaffective Disorder. This is a patient who has an uninterrupted period of illness, meeting symptoms of the positive symptoms of schizophrenia. And what are those again? The uppers, the hallucinations, delusions, disorganized thought processes. So these patients will meet the positive symptoms of schizophrenia concurrently with either a major depressive disorder, manic episode, or a mixed episode. So not just schizophrenia, but they will also have those symptoms as well. So it is very important when you look at the patient and look at their diagnosis, you will see schizophrenia, so they have the positive symptoms, but this is a patient who's also saying, I'm so depressed. It must be present for at least 2 weeks of only psychotic symptoms, of delusions and hallucinations. And the mood disorder must be present for a substantial portion of the total duration of the disorder. A delusional disorder. This is another disorder. These are non-bizarre delusions lasting at least 1 month. The positive signs of schizophrenia have never been met. Apart from impact of delusions, their functioning is not markedly impaired, so they otherwise function normally. They have prominent non-bizarre delusions like the grandiose type, the jealous type, the persecutory type, the erotomanic type, like they think someone's in love with them. So this is a delusional disorder. And you do have some people just walk around in a delusional state. Then you have the brief psychotic disorder. Sometimes this can happen after a traumatic event, sometimes after ingesting some weed, some drug, something. A lot of times it's some weed. And this is why I try to tell my young people, marijuana, while it is proven to have its medical benefits, I have seen a lot of patients where if they have an underlying mental health issue, they smoke marijuana, it kind of just brings it right up there. And all of a sudden they have these symptoms. Very rarely it goes away when they stop use. Sometimes it comes up and it's there to stay. Stay away from the marijuana, guys. A brief psychotic disorder is the presence of 1 or more of the following positive symptoms: delusions, hallucinations, disorganized speech, often incoherent, or grossly disorganized or catatonic behavior. The duration of the episode is at least a day, at least 1 day, but less than a month. So they can have it at least 1 day or less than 1 month. They can have eventual return to their pre-morbid level of functioning. So before they had this brief psychotic break, they can return to normal and be like, oh, this one time in my life. So sometimes I'll have patients who come to see me because very likely after they have this one break, their family members is going to bring them to the hospital and they're going to start medications in the acute care setting. And this patient will come to see me and it's 6 months later, a year later, and this patient has never had any other symptom of this break. So usually around that mark, we'll start tapering away the medications to see, was this a one-time psychotic break or do you have symptoms that are being controlled by the medication? I have 2 patients right now where we are coming up to the point where we're going to start tapering them off the medication because they only had this one psychotic break to see where they stand. Then we have the full I do. This is be careful of the company you keep. This delusion develops in an individual in the context of a close relationship with another person who has an already established delusion. So whether they have schizophrenia, whatever disorder they have, but they have delusions. And now you're like, yeah, it's true. I see it. I hear it. And this happens simply because you're associating with this person. Prevalence is more common in females, and it's not better accounted for by this person having any mental illness themselves or anything else going on themselves. Okay? So you are the company you keep, or you can be. The full I do. Treatment. Psychotherapeutic interventions. So you want to make sure all those non-pharmacological treatments we discussed, the CBT. If they're using drugs and alcohol, you want to get them in rehab. You want to teach them healthy lifestyle. You want to get them the treatment they need so they start living healthy lifestyle. We mentioned the ACT team before in our last class. The ACT team goes out and helps them with their activities of daily living in their lives so they can function, so they can live in the community and get things done. Group therapy, social skills training, someone who just had a brief psychotic disorder or just got diagnosed with schizophrenic form, schizophrenia. Group therapy will be good. Just imagine how life-changing this entire thing is for them. How comforting would it be to get in a group with young adults and realize, whoa, other people have this disorder too, and they're still functioning, and he's still in school, and he's still working. So group therapy works to benefit them. Teach them symptom management, de-stress, find making time for themselves, engaging in fun activities. Help them to identify their triggers and relapse prevention. Smoking cessation, it's a huge one for schizophrenic patients. It is mentioned that patients with schizophrenia have a lower, have something in their brains that lets them smoke more, like nicotinic receptors. They smoke more than the normal person. So most people, 60% of people with schizophrenia are going to smoke. And when I say smoke, I mean they're telling me a pack a day, like they're smoking. They have a hard time quitting. One drug that is used, one antipsychotic drug that is used that helps with smoking, it treats schizophrenia but also helps with smoking, is clozapine. We should also teach patients that smoking interferes with how the drug is metabolized. We will discuss clozapine as we go forward in the class as well. They will need help with housing because this patient will probably have lost their jobs, probably gotten kicked out of their homes or families years ago because they did something bizarre. Their husband probably left, their wife probably left. They'll need vocational training. They'll need home visits, and the ACT team will come in place. If this is someone who is still at home, the family will need support. So you probably want to make sure they have like a visiting nurse, a home health aides, someone to help them around the house, to help them with the medication administration as well. The pharmacology for this psychotic disorder. So someone is psychotic, you give them an antipsychotic. Antipsychotics, there are two different groups. There is it's called the first generation, and then you have the second generation, also known as the typicals and the atypicals. First generation, second generation, or typicals and atypicals. The first generation, the first slide here talks about the second generation, the atypicals. These are the first choice. And they're first choice because they have a lower side effect profile than the typicals. With the exception of clozapine, olanzapine, because of the metabolic side effects. And when I talk about metabolic side effects, antipsychotic drug use can cause patients to have diabetes that they never had before. And this is something you have to educate your patients about, the metabolic side effects of these drugs. Clozapine in particular is one drug that is used for, usually if a patient is on clozaril, they would have tried 2-3 antipsychotics prior. So if you encounter a patient on clozapine, it is very important to recognize that clozapine is like NK scenario. Because when patients take clozapine for the first 6 months that they're on clozapine, they get blood work every single week. If they don't get the blood work, they don't get the med. There's a REMS system where I have to check in as the prescriber, the pharmacist has to check in as a distributor, and the patient has to go to the lab to do the lab work for the pharmacist to get the lab results, and for myself to get the results so I can prescribe and for them to get the drug. So it's a lot of monitoring. That's the first 6 months. For the second 6 months they're on this drug, they get blood work every 2 weeks. So that's a year of blood work. And then for the rest of their life, if they're on this drug, they get blood work done every single month. So you're doing discharge teaching for a patient who's on clozapine, you want to make sure that they understand what the drug is, what the treatment, what the target is, and also what is required to take this drug. Because this is not the patient you're going to send off on their way without setting up an outside provider, finding labs in their area, because this drug needs to be monitored closely. And it needs to be monitored closely because it can cause agranulocytosis. That's a huge side effect of clozapine use. So for every patient that has it, every time I log in for my appointments, I look for their blood work, look at the last ANC, and make sure their ANC is still within range. The benefits of these atypical antipsychotics: they work on the positive and negative symptoms, and they lower EPS risks. EPS, we will discuss that a few slides down. It's the extrapyramidal symptoms, and these are side effects, body movements that you get from using antipsychotics. The side effects could be sedation, hypotension, weight gain. Weight gain is a huge one from antipsychotic use. They could have, like I mentioned, glucose dysfunction, sexual side effects, issues with their heart. So antipsychotic use should be reserved to absolutely necessary use. Like very often you'll see patients taking Seroquel for sleep. Seroquel is quetiapine. It is an antipsychotic, but it's very sedating. So word is on the street, Seroquel will make you sleep, and everybody is asking for it. But then very often after I educate them about the side effects of Seroquel, do you still want Seroquel for sleep? Oh, no, give me something lighter. So education is very, very important for these patients. So one class of antipsychotics is the penes, which is also the atypicals. The second generation, you have the penes, which is the clozapine, olanzapine, asenapine. So get to know those names, familiarize yourself with names, new intake, you're on the unit, you're going down and you see clozapine right away. How long is this patient going to be here? When was their last blood work? When is their last dose? Because these are medications that you can't just let a day or two pass without giving it to these patients. Olanzapine, which is also called Zyprexa, it's given in different forms. It can be given if a patient is like agitated. I mentioned quetiapine. This should have been bold as well because that's an antipsychotic, quetiapine. Patients who take these drugs can have eye changes, cataracts. They can also be used for not just schizophrenia, but also for a bipolar disorder, because bipolar patients, when we get into that, will have like manic symptoms as well. We have the dones, the risperidone, the zyprasidone, lorazepam. These drugs are also very, very commonly prescribed. The key thing about risperidone is it increases prolactin, and we know an increased prolactin level, especially in males, can cause lactation. Yes. What's erectile dysfunction? Yes, sexual dysfunction. So you want to make sure you're educating the patients to look for these things. Look for these things. Is your breast going to start growing? Make sure you're paying attention to these things, because it's not a definitive thing that's going to happen, but it can happen. There is zyprasidone, which is the Geodon. It is lower on the weight gain side. Patients should be educated to take it with food. It also comes as Invega, which is an injectable. There's Latuda. Latuda is often prescribed for a bipolar disorder. It is one of those medications that is used for bipolar, Latuda. So there's a lot of education around these drugs. Patients need to know the side effects, how to take them, why they shouldn't just stop taking them as well, and the target symptoms. Then we have Abilify, which is the PIP. It's aripiprazole. I prescribe this pretty often too. It has a lot of lower side effects. I often use this in children, because when the children come in there with the DMDD and those explosive, they can get a little bit of antipsychotic, like a little bit of Abilify, 1 milligram, something very small, even smaller than. And very often it works. I had one patient the other day over the summer. His mother called me. She said, "Zoe, I need something. He is hitting his siblings. He's not following any rules. He's running around the house. He's ripping stuff up." So I gave him a very little low dose of Abilify with the agreement that it would be 1, short term, and 2, she was going to increase therapy. So I've only had 1 follow-up since he's been on it. It's working like, even the child says, "I noticed the change. I am doing so much better." The hope is not to keep him on this drug. He's young. I want him to learn how to function and to follow rules with therapy or drugs less potent than an antipsychotic. And then there's Rexulti, one of the newer ones, brexpiprazole. Here's a list, first generations, and these are the big guys, the Thorazine, the Haldol, the Mobane, the Navane. You will still see these prescribed, and you will still see these prescribed because they work better on the positive symptoms. So while the atypicals work good for both positive and negative, sometimes you're treating patients and they just can't stop having those hallucinations or those delusions, no matter how many times you change the atypical or increase the dose, they just still have those symptoms. So you switch them to a typical, and very often it's taken care of. But we try to stay away from the typicals because they developed a second one for a reason, because the first one was too many side effects. So that's why they developed the second one. So, but sometimes you still see them being used. It's a greater chance too for the EPS and the TD, which is the tardive dyskinesia, and the extrapyramidal symptoms. The typicals usually cause those movements more. What are EPS? These are motor movements involuntary movements caused by the medication use. That's the dystonia, the involuntary muscle contractions. It could be pseudo-Parkinsonism, so it kind of looks like Parkinson, only it isn't. The shuffling gait, the slow movements. It could be bradykinesia, that slow, reduced muscle movement, or it could be even akathisia, that restlessness, that inability to sit still. That's EPS. EPS, early. E for early, it usually appears pretty early on in the antipsychotic use. So as the nurse, you will assess for patients by doing the AIMS test. And this is a test that checks for their involuntary movement. So you have them do, it comes with instructions, it'll tell you to tell them what to do. And as you're doing these things, they will be looking you'll be looking for movements. There's a video I usually post. I'm going to reach out to Pam and have her post it about EPS symptoms so you can have a visual of what they look like. So this is the patient. I have patients come into me and they're like, and they have no control over that. This is what the medication has done to them. Or they tell you their fingers are dancing, the finger dancing, or in just talking to them, they're sitting there talking. I'm going to pretend this is the arm of the chair, and their hand is on the arm of the chair, and they're just constantly doing this. They have no control over it. Or you notice that their ankle is just like twitching, or they're moving their legs back and forth, the restlessness. So while I'm talking, asking them, so how is your sleep? And how are you spending your days? I am looking at them from head to toe, because sometimes they themselves don't notice these movements. There are drugs that are given to help with EPS. That is usually benztropine, cogentin. So the patient is taking an antipsychotic, you will most likely see benztropine, sometimes even Benadryl prescribed prophylactically to ward off these signs and symptoms. So long-term use, those movements, when those movements start, it's recommended that you either reduce the dose of the drug, change the drug. Because if the movements continue, they can set in, and that's when it becomes TD, tardive dyskinesia, late onset. And then those can be absolutely permanent. So my long-standing patients that have been taking these drugs for a great portion of their lives, when they come to me with all those movements, that's it. It's theirs. There's no getting rid of that movement. So can this person function in the normal world of work with all those facial grimacing, tongue movements, and all that stuff? I have one patient, she's Jamaican, and I mentioned that I'm Jamaican, and in Jamaica, their mental health care is not there, nor is mental health recognized. But she has schizophrenia, and she's been treated, which is good. And the first time I met her, she came to see me, and this was her. And she's holding on to the back of the chair, and she's twisting, and that's her truncal movement. And I'm like, hey, you have some TD going on over there. She goes, no, it's just my back. My back is hurting. 3, 4, 5 visits in, same movement. It's her back that's hurting. She refuses to acknowledge it. But it's the medication used. And I think she's on like Haldol. She's on one of the big guys, like one of the first generations. But it is what it is. It causes it. And unfortunately, some patients will not take the medications because they notice that it's starting these movements. So they will opt to be in a psychotic state because of the medications. And it's sad. You understand the rationale, and it's hard to blame them, because I can't imagine being afflicted with those movements because I am trying to cure or treat something. There's no cure to treat a disorder, and then this is what happens. So that's the lip smacking, the sucking, the tongue protrusion, the worm-like movements of the tongue, the grimacing, the eye blinking, the rocking. So lots and lots of different movements. So very often when you see patients and they don't look quite right, and they're like leaning over, like I have one young man, his head is like this, and he keeps his hands up here, and he's just like this the whole time. It's the medication. It is the medication. He's been on it for years and years and years. But if you have a conversation with him, he's missing several of his teeth. He's totally deshelled. He's odorous. He's such a pleasure to talk to. Hi, Miss Zoe. How are you? And I very often see him when I'm driving on the streets, because he roams the streets, and you'd probably think you wouldn't even put your window down if you saw him. But if you ever knew him, you'd realize there's a person inside. So there are some programs like at IOL, they have the 10 program, early intervention programs. At Yale, they have the PRIME program. And these are programs that will help the patient to explain their illnesses, medication use, to help them to get a better insight into what's going on with them. As mentioned, the typicals decrease the positive symptoms, but they cause movement. The newer ones, the atypicals, they block serotonin receptors to reduce the negative symptoms, as well as the positive ones as well. The second generations, or the atypicals, are not so bad with TD. It's even thought they can improve the TD. There are fewer side effects than the first generations. Nursing assessment, Make sure you're looking at the patient's perception, thoughts, feelings, behaviors. Make sure you're assessing them thoroughly, because you want to know what they're hearing, seeing, feeling. You want to have a good picture of what is presenting in front of you. You're going to observe for positive as well as negative signs, because you're not going to say, oh, I have this positive sign, I'm hallucinating. You should hear hallucinations, no positive symptoms. You're going to assess for safety, the risk for violence. Are they having command hallucinations? What's the risk with command hallucinations? Yes, they may act on it. So command means someone's telling you to do something. That voice in there is telling them, you should just kill yourself. What's the point of living? Why live another day? Jump off that bridge. Or you know what? You should kill your husband. Yeah, just stab him. So these are what patients tell me that they hear. Voices telling them to do things. So in a case like that, that is a patient who should go right to the top of your priority list. Patients with command hallucinations. Is that a movie, Son of Sam? Yeah, I know that. It's a movie, Son of Sam. I don't think I've seen it, though. Wait, it was a real person? Is that the person who killed kids, I think? I have a lot of TV watching to do. At discos, oh. So a patient tells you they're having command hallucinations, red flag, double red flag. You want to assess for safety, the risk of violence to selves or to others. Do a mental status, like we discussed, possible nursing diagnoses, alterations in thought processes, risk for self, risk to themselves or others, ineffective coping, not just for the patient, but it could be for the family too. Self-care deficits, they could have knowledge deficits, they could even be in denial. I am fine, I don't need these meds. I don't know what happened. It was probably just that bad batch of weed I smoked, but you have to try to educate them. And there's a huge list of nursing interventions. Self-management, assess and monitor for safety. Make sure you're using your therapeutic communication styles, because as these patients have these hallucinations and delusions, this is not the patient you want to walk in there and you're confronting them. You want to make sure you're reorienting, stating, restating, clarifying, so you get a good understanding of what is presented. Provide low-key interactions. This is not the patient who probably needs to be around the nurse's station with all the laughing and the excitement going on out there and the noise. You probably want this person at a quieter end. This is also not the patient you're going to leave by themselves either if they're hallucinating, having delusions. You probably want to also keep them aware or have a sitter, someone who can keep an eye on them. Again, emphasize the importance of taking the medications regularly, because very often they'll start taking the meds, they start feeling better, and they will think, I am better, not attributing their improvement to the medication that they're taking. And of course, please lose your ability to be empathetic with your patients. You're going to assist them with hygiene. This is the patient who's probably there for a week and doesn't shower. A little nudging, set up the stuff in the bathroom, get someone to help them. You want to make sure they're nutritionally stable. They probably won't be hungry. They probably won't eat. They're in this manic phase or something. You want to make sure you're offering foods, even having someone sitting with them, make sure they talk them through the meal. Listen actively. You're going to work with the patient on relapse prevention management. What happened last time? Why you had the psychotic break? Or I stopped taking my med, or was using drugs. So you want to help them through these symptoms. Educate both patient and family, meds, stress reducers, the importance of sleep. Sleep is very, very important, guys. You need your rest. Like I tell my patients, you need to rest and recharge that brain. As you're teaching, make sure you're simplifying the material. You want to reduce distractions. This person already has a lot going on in there. You don't want to be teaching them outside in the hallway where people are walking around talking to you. Reduce your distractions. Use clear, direct voices. Teach them a little bit at a time. You do a little here, you go, you come back a little bit more. Not too much. You don't want to overload them. They already have a lot of internal stimuli going on, possibly. Do not offer confusing choices, avoid gestures, or result in echopraxia, like them repeating your actions. Work to reduce their stress. Treatment here, it goes on to mention again that they could be doing ECT. We spoke about ECT last class. It could be therapy, individual, group, or in a milieu. CBT, DBT. They may need help with occupational, recreational therapy. And that is the end of our psychotic disorders. Any questions?